Good afternoon, everyone. So here we are on Friday for a live to talk about menopause and pain. So this discussion comes up again and again as I see patients in my office, and oftentimes it's unrecognized as to what's going on. So I really thought that I needed to share. So when did I first notice this? Well, number one, it happened to me. So when I was about 44, I remember getting pain in my right knee, and the pain was just there all the time. There was no swelling. There was nothing that was obvious. I had someone have a look at it. There didn't seem to be anything inflammatory going on. And I was like, what is the problem with my knee? So it was several months after that I started on progesterone therapy when I was younger, I guess in my mid-40s, because I had a cyst that was developing on my ovary and I was having some menstrual irregularities. And when I started on progesterone, I really noticed that this knee pain was getting much better. And I thought, wow, so my joint pains could be related to my menopause or these hormonal changes. And then the next came for me just a couple of years ago when I ended up having the left ovary out and I was already postmenopausal, but I found that I was starting to get a lot more back pain, much more intense, and just aches all over my joints. So when you go through menopause, so we know that the hormone production goes down so that you stop having your periods, but we still have decent hormone production often for the next 4 to 5 years. But I really felt that when I had my left ovary removed, and this would have been about 9 months after, that I think I really had a much more rapid drop in my estrogen at that time. And all the muscle joint aches and pains were really coming. And the back pain was much more intense than I'd ever had before in my life. And I also noticed, actually surprisingly at that time too, that my muscle mass was really starting to decrease. So I wanted to share those things that I personally experienced because now we're actually starting to recognize this much more in the menopausal space, and I'll say along the menopause spectrum. So anytime from your 40s up until, of course, into your 50s. And so in the spring of this year, Dr. Vonda Wright, who is an orthopedic surgeon from America, she published a research article. This was in May. And just like in medicine, sometimes we don't have terms to describe things. So for many women, you understand that we now have a term to describe the vaginal changes that we go through in menopause, and we call that the genitourinary syndrome of menopause. But Vonda Wright and her colleagues propose a new term, which is called the musculoskeletal syndrome of menopause. So why is this being introduced? Well, she has noted as an orthopedic surgeon that she's seen so many women come in the menopause transition that are having pains. So when they look at the research, over 70% of women are going to have substantial changes as they go through the transition. But for up to 25% of women, this can actually be disabling. And this is a very under-recognized problem within menopause, within medicine, because doctors are just not aware of it. Even for me, I was not aware of the significance of these pains that were happening. But of course, when I felt it as a doctor and as a menopausal woman, then I knew this is something that needed to be addressed. And also in medicine, when you go to see your physician, what happens is that you go in and maybe you do have an x-ray, but with over 40% of women, there's nothing structural to find. So the doctor says, well, your x-ray is normal and you're okay. But you know that you are not okay because you're really feeling these pain and these symptoms that you never had before. You might have been doing your same level of fitness, going to the gym, doing your walking, doing everything the same, but yet your body is starting to shut down on you. So this is extremely important and we need to address it because pain can happen in many different ways in menopause. And what I've seen as a clinician that's treating women in this time period is that they come in to see me and they've been given pain medications. Often they're on an anti-inflammatory like Celebrex. Maybe they're even taking something like Cymbalta or Lyrica for their pain. Or maybe they're even on painkillers like Tylenol 3 or even Percocet or OxyContin because they have this pain that's not being diagnosed. So what is going on? Like what are the conditions that we have to look at during this time period? So a lot of this is referenced from Dr. Wright's paper and then some of my own information, and I'll share her article with you below. But number one is inflammation increases during the menopausal transition. And this is primarily due to estrogen's role. So estrogen, which is one of our chief female sex steroid hormones, begins to decrease and fluctuate. So we know that in the early part of perimenopause, that progesterone decreases first, and then estrogen starts to change. So with these hormones that are decreasing, we can definitely see a heightened level of inflammation in the body. And my first experience with this was the decrease in progesterone. And that's what happened to me. I was still having regular cycles. And I remember when I was studying the endocannabinoid system. So the endocannabinoid system is related to CBD and THC, okay? So we have this amazing system within our body. And I met a researcher when I was at a conference in Israel. And this really stuck with me, and it made me recognize what went on in my body. Because he said that when he wanted to induce pain and inflammation in rats, because he was doing research, he would cut their progesterone receptors. When he cut progesterone, these rats were in extreme amount of pain. So what we want to do, we've got some people coming in here now, is that we have to realize the importance of these hormones, estrogen and progesterone, in the whole inflammatory cascade that goes on within our bodies. So what else is also shifting that can contribute to pain during this time period is we can see osteoarthritis that is increasing. And when they look at the facts, why does osteoarthritis increase? And if you're a perimenopausal woman, you might notice it as in your knuckles, within your joints. And this is what I found, especially in the distal parts of my joints, that they were starting to swell at times. And this is because as estrogen decreases, the connective tissue matrix, so this is what kind of the glue that keeps all of our bones together, so it begins to change as we go through this time period. So inflammation through osteoarthritis can be increased, and this can cause a lot of pain during the time period. And again, often you may have an x-ray that might show minimal changes, but also it may not show any changes at all. And the other that I've begun to see is that a lot of women are coming in and they're actually being diagnosed with conditions like seronegative rheumatoid arthritis. And I've seen this again and again, and I wanted to really bring it up. So rheumatoid arthritis is an inflammatory condition. Often it can start in childhood, or it can start with women when they're in their early period, like in their 30s. But if you've been diagnosed in your 40s and 50s, then what seronegative means is that your rheumatoid factor antibody in your blood is actually negative. So you go to see a rheumatologist because you're having lots of muscle aches and pains. They do blood work on you, but your joints are swollen, you're stiff, and your blood tests are actually negative, but the specialist may say you have seronegative rheumatoid arthritis. So my question is this really rheumatoid arthritis, or is this truly the estrogen drop and this musculoskeletal syndrome of menopause? And why it's really important to be aware of this is because if you have rheumatoid arthritis, there's a whole cascade of immune modulating drugs that rheumatologists will put people on. It may start with something like methotrexate, which is an anti-cancer drug, which actually shuts off your immune system. And there's a lot of other medications that may be involved, even to the point where injectable medications may be involved. But what I would say is you need to look at whether this simply is related to the hormonal changes that are going on during this menopausal transition. Because if you address this through menopausal hormonal therapy, not only are you going to help with the actual root cause of the problem, which is the estrogen itself and the progesterone, but you may save the harmful side effects of being on these potent medications that are actually going to shut down your immune system. So that's arthritis to consider. The other thing I want to talk about is the drop in bone density. So bone density drop is going to start as soon as you go through menopause. You're going to start to lose up to 10% of your bone density. And we know that after menopause, you're going to lose your muscle mass up to 0.6% per year. And I've noticed that. And if you're a woman that's gone through menopause, you're going to see it because the muscles are they can often be more weak than they were before. Maybe you're seeing it as more jiggliness or more cellulite that's happening, but it truly happens. So when we lose the bone density, that's going to make us more prone to get osteoporosis later in life. And osteoporosis is not the problem, but the fractures that result from it are. And we know that when women have a frailty fracture later in life, it actually can go on to increase their risk for death and other problems within that year, especially if it's when you're in your advanced age into your 70s and 80s. But one of the bigger problems is the loss of muscle mass. Because when your muscle mass is lower, you're not protecting your joints. So when your legs are strong, you're able to protect your hips. When your arms are strong, you're able to protect your shoulders. But when muscle mass goes down, and if you're not doing the fitness to maintain it, then you can start to have a lot more problems within your joints because of that loss of muscle mass. So this also went into this condition called sarcopenia, and this is the loss of the muscle mass that comes with aging. And often you'll see this as women get older, and men as well, is they were robust individuals when they were younger, but then the muscles began to get weaker, and this is going to contribute to their frailty. And frailty means getting weak, getting to the point that you can't pick up your groceries, you can't carry them in, that maybe you can't carry your grandkids, that you can't really bring the wood in and put it into your basement. Those aspects of frailty can contribute to a lower quality of life. And I know for me, when I started getting weaker, in my late 40s, I was, did a lot of kayaking, and I like to canoe, and I didn't have that strength to be able to lift up, the canoe and carry it like I could before. And also carrying groceries like up several steps. When I was living in Bermuda, I had a long way to carry my groceries. And I said, there's definitely something going on here. And that was the menopausal changes from my drop in estrogen, which really encouraged me to do more weight-bearing exercise. So what else is happening during this time period? We're also having a drop in our stem cell production. So you might have heard about stem cells, because you can actually, in many areas now of the world, go for stem cell therapy. But our body naturally can make stem cells, but estrogen really is a potent marker that contributes to our natural stem cell formation. So we know that periods of fasting can actually help to activate our stem cells within our body. You can get stem cell infusions, but we want to maintain our stem cell mass as much as we can, because again, it can help reduce inflammation within our bodies. So one of the regions within our body that people don't talk about is this area called the inflammasome. So this is inflammation that develops within our body, and there's many factors that impact the inflammasome. So one would be our hormones, the drop in our estrogen and progesterone. One is also going to be the lack of our testosterone as that goes on further on into the menopause transition. And also the gut microbiome can negatively impact our inflammatory markers too as we go through the transition time period. But what does that do? Again, it modulates the pain response in the body. So you can go to your doctor, you look fine, your joints aren't swollen, there's nothing that they can structurally see, but you know that your body is not feeling good. And this leads into the last condition that I really wanted to talk about, which is fibromyalgia, because I see so many women that have been diagnosed with this condition, which is real. Fibromyalgia is a condition that in medicine, we have it termed as a default condition. It's kind of like irritable bowel syndrome. So the doctor will do the blood test or they'll do the x-rays, and if everything is negative and you have some sore points along your body, then they'll say this is fibromyalgia. And it is a true painful condition, but what we haven't looked at in medicine are the best ways that we deal with this condition. And for me as a functional medicine physician, I'm always looking to get at the root cause. And for many women, I see the hormonal changes as are a significant contributor to fibromyalgia. And why is it concerning? Is that again, women are being placed on medications, they're strong nerve medications, strong antidepressants, which can have other side effects, but they're not getting to the root cause. So if you're in this time period and you may have been diagnosed with fibromyalgia, I want you to think, okay, where am I in my menopause transition? Am I still having cycles? If so, then I want you to think about, are my symptoms worse the week or two before my menstrual cycle? If you are in the menopause, like really perimenopause transition, and your cycles are coming like every 1 or every 3 or 4 months, and you've been starting to have a lot of pain, and you've been diagnosed with fibromyalgia, then think, maybe I really need to think about hormonal therapy, because this may be a contributing factor. And for sure for women, if you have stopped your cycles and you're having a lot of pain and the doctor says, I think it's just fibromyalgia, then you need to think about, what about menopausal hormone therapy? So for all of these conditions, as we can kind of summarize it together, so this pain that happens in menopause, we've got inflammation, we've got a loss of your bone density, a loss of your muscle mass and sarcopenia, we've got stem cell production going down, and we've got this inflammasome, which is activating osteoarthritis and also some of the autoimmune conditions like rheumatoid arthritis. We have to consider that this can be all of the package in hormonal changes that are going on in our body. So then what do we do about it, right? So of course, this is unique to every individual, but there's some fundamentals that I would say. Number one, and Dr. Wright talks about 3 things during her article. Number one is adequate amounts of vitamin D. And in particular, in the West, and especially in the North in Canada, I would say every woman is going to need to have at least 2,000 international units of vitamin D almost all year round. And along with that, you're going to need to have vitamin K2. Vitamin K2 is very important, not only for the absorption of vitamin D, but it's also important in our metabolic pathways, that it can help to control our metabolism and our energy balance and weight. So those would be essentials. The other essential that I want to talk about is omega-3. Almost all individuals need omega-3 in their diets because we're not getting sufficient amounts of fish oils. For me, I recently had my omega-3 tested. My marker, my 3-to-6 ratio was very high. It was at 21-to-1, which I was really surprised at. But I think I wasn't taking a supplement during the time, but I think in our northern diets, we don't eat enough fish. So omega-3s would be an essential that I would talk about. Vitamin D3, vitamin K2. Dr. Wright also talks about protein. Women and men, you need adequate protein, especially as you're aging. Because of the loss of muscle, as we're getting older, this estrogen-related side effect, or for men, a testosterone-related side effect, we really need to get sufficient protein. Protein is an amino acid. It is essential building blocks for our muscle. And this is roughly a gram per pound of body weight. So this can be anywhere from 60 to 100, 120 grams of protein a day. And the other Dr. Wright speaks about in her article is creatine. Now, creatine is just not for bodybuilders. We know there's a lot of significance and a lot of research right now. Dr. Stacy Sims speaks about this highly too, is that creatine is beneficial for our muscles in terms of maintaining muscle mass, and creatine also has a role in improving our brain health as well. So those are the supplements that can help you through this time period. What other things that you can do? Number one is you have to think about moving your body. If you're sedentary like most North Americans, we know that sitting is the new smoking. You need to get out and move. You need to get out in the sun. Today I'm in a different city. I'm waiting for some family members. I'm in a parking lot, but still I'm exposed to sunlight. We need to be moving. And then the other thing I want to speak on briefly is the breath and the amount of work that we need to do there. We know that a lot of inflammation, a lot of the things that I spoke about today are because the body is also in this heightened stress response time period. We know that many people are living in a very strong sympathetic drive. So what does that mean? People are busy. They're rushing around. It's all about fight or flight. Well, for our body to get into healing mode, or what we call rest, digest, and heal, this is our parasympathetic nervous system. These two systems are living in a constant balance. But for the majority of women that I'm seeing coming to see me in my practice, they're living in a heightened sympathetic response. They're getting up in the morning. It's get a cup of coffee. It's go out the door, get the kids to school, get to the job, come home, and then make supper, and then have a little drink of wine to relax, and then try to get to bed on a decent time. But we need to activate the rest and digest and healing part of our nervous system. This is where mindfulness comes in. This is where breath work comes in. This is where meditation comes in. So yes, I think hormonal therapy can help so many women, and it's been life-changing for so many of my patients. But I think all women, no matter where you are, you need those essential nutrients that I spoke about, and you also need to incorporate something that is going to help to activate your parasympathetic nervous system, because we want to engage the healing of the body. We have a body that is able to heal itself. Many times we need to guide it a little bit along the way, but think about what are those activities that you need to do. So if you need any help along your journey, I am here. I've been doing this medicine for 26 years now. I'm a 53-year-old postmenopausal woman that's had her share of issues. So if you want to get some health on the journey, keep following me here on Instagram, or feel free to book in with me. I do in-person and virtual consultations. I hope this has been helpful. Please share any comments that you have below, any questions that you would like me to answer. I'll respond in your comments. Have a wonderful weekend. Bye for now.